Dr. Mustafa, you can start now. We have crossed 500 audience.
Assalamu alaikum wa rahmatullah. Good evening, everyone. I would like to thank Saudi German Hospital organization for organizing this webinar. And I would like and it's my pleasure to introduce Professor Helmus Steinmetz from Germany, Goethe University Hospital. He is our visiting professor since many years till the pandemic start, and I hope to meet him this year, inshallah. He will speak about the Stroke News 2021. And it's my pleasure also to be here with Professor Mahmoud Sabri from Saudi German Hospital Riyadh, and Professor Shireen Faraj from Saudi German Hospital Cairo, and Dr. Muhammad Fuad from Saudi German Hospital Medina. Please, Professor Helmus, we are waiting to hear from you.
Dr. Mustafa, thank you very much for these nice words. A warm welcome from Frankfurt, Germany. And if you wonder where I'm sitting here in the picture in one of these tiny buildings in the background of this photograph. This is the main building of the University Hospital. The Neuroscience Center is here. That's where I'm now speaking from. Hello to you. And it's my third webinar to the SGH community. I'm very pleased to see that 500 people are watching and hearing. And I'll start now. And I have 40 minutes and want to present you some highlights from the stroke field in 2021. Now, some of you may think, what, 2021? It's just 120 days or so. But indeed, there have been a number of very impressive findings, results, and treatment progresses in the field of stroke in the first quarter of 2021. And I will show them to you, as always with my webinars. The slides are built like this. That's the anatomy of the slide. Topic is up here. The data I'm talking about from papers that I read are in the middle, and the message is in the bottom. So that's the anatomy of my slides. Those are the topics I will cover. I found 9 papers interesting enough to present them today, and they're from these results. It's as always, since 12 months, I'll start with some news from the COVID pandemic and its relationship to stroke. I'll cover some interesting aspects of epidemiology, some clinical points about a special hobby of mine, the question, what is a TIA and what is not? I'll talk about mobile stroke units, the 2 interesting papers around extended time windows for acute recanalization treatment, mismatched imaging, the question of TPA to be used with endovascular treatment or not. This abbreviation will appear many times in my talk, EVT, standing for endovascular treatment. And within this, I'll cover 2 hot topics from the International Stroke Conference, which was held online 10 days ago in the US usually, but in this case it was online. And there are 2 non-published papers that were presented there, which very much impressed me, and I will include them in my talk. So let's start with COVID. That's, as shown for the last time, that's the logo of my university hospital currently, the COVID logo. Those are the small viruses entering the nasal epithelium. And what is new? This is really new. This is only a few days old. And as I know, at least in the UAE, you are using AstraZeneca vaccine, the same as we do in Europe and in Germany also. Unfortunately, only 10% of the German population has been vaccinated as of today. But many of them, a couple of millions of them, were vaccinated with the AstraZeneca vaccine. Maybe some of you also. And a very most recent observation is that here in Germany and in other European countries, we are confronted with patients presenting 4 to 16 days after the first AstraZeneca vaccine application with a special syndrome, which sometimes start with petechial bleedings, and then moves into cerebral sinus and vein thrombosis in combination with thrombocytopenia. That's of course a very unusual combination. So a fulminant thrombosis, very severely affected patients, combined with thrombocytopenia, and it apparently seems to be 1 in 100,000 vaccinations. So that's still a very rare event, but due to this combination of sinus vein thrombosis plus thrombocytopenia, mostly younger women, and all of them having been vaccinated within the last 4 to 16 days, makes it likely, that's our impression currently, that this is a rare side effect of this vaccination with this special vaccine. And the most recent term for it proposed is vaccine-induced prothrombotic immune thrombocytopenia. And it apparently seems to be immune-mediated, very much like heparin-induced thrombocytopenia. And the first treatment recommendations for that are not heparin, but IVIG, or maybe plasma separation. So because you have to extract the antibodies which have apparently occurred due to the application of the vaccine. So that's a very recent finding in the context of COVID, the vaccine-induced venous event. What about arteries? So acute ischemic stroke, there had been much worry about whether acute ischemic stroke may be increased in the COVID-19 patients. This is the case. That's the best study so far. Was another study from 2021 in 27,000 patients from 54 USA large healthcare facilities. These 27,000 patients were admitted with severe infectious syndromes causing the suspicion of COVID-19, and 8,000 of them turned out to have COVID-19, and the other 19,000 turned out to have other systemic inflammations. And the results in this study was that 1.3 patients of the COVID-19 group suffer from arterial ischemic stroke, acute ischemic stroke in the context of their condition in the next 3 weeks, compared to 1.0% of the patients with the other infectious conditions. So that's a significant increase, but certainly acute ischemic stroke is not a major feature of COVID-19. If it happens, then it's a very severe event. So the acute ischemic strokes happening in COVID-19 patients is usually a double as severe as in the context of other infections. The other observation is that all of them occur in the context of other conventional, let's say, arterial traditional risk factors such as hypertension, smoking, diabetes, and history of coronary heart disease. So it's a risk factor related, but probably due to the thrombophilic stimulation, final event or within COVID-19 severe infections. 1.3%, not much, but severe as when it occurs. So that's all about COVID in the first quarter of 2021, COVID and stroke. Another paper that I found very interesting was in JAMA Neurology a couple of weeks ago. I must say JAMA Neurology is currently the most interesting neurological journal. Many of the big papers occur there. And this was one confirming that stroke remains the neurological condition with the highest disease burden in the Western, at least, populations. This is from the United States. It's the DALYs, the DALYs, that's disability adjusted life years attributable to stroke. The DALYs, it's a measure of disease burden. It's a sum of life years lost and life years lived in disability adjusted by the severity of the disability. So it's a measure, it's an estimate of the relevance of disease for a population, and it's age standardized. So it does not depend on the demographic situation of your country, which is an old population in Germany, it's a younger population in Egypt Saudi Arabia. So that's age adjusted, and you see that the DELIs remain stable more or less with a trend of going down in the last 30 years. And this apparently seems to move up a little bit since 2010. So we may enter a phase of increasing incidence and burden again. I would guess, and that's also the interpretation of this paper, that this is due to improved risk factor management, smoking, hypertension, physical activity have been improved, have been better managed than in the 70s, 80s. Maybe other factors are now contributing to a beginning increase again. Certainly not due to age, because it's age standardized. Maybe due to, again, increasing risk factors. That's my guess. Now, if we could communicate more easily, I would now ask you, what's your guess? What's the second in this ranking? The second most relevant condition in terms of neurological disease burden? I don't know. Maybe many of you would say it's dementia. That's what I probably would have guessed. But according to this paper, it's migraine. So migraine is, in terms of DELIs, a similarly relevant disease in terms of days lost of productive and enjoyable life. It's around 700, not far from stroke, and remaining completely stable, since there's no risk factors and there's no therapeutic breakthrough, so it remains stable. But even some of the neurologists underestimate the epidemiological burden of this condition, especially in the women of the first half of their life, so younger women. So big thing, migraine still remaining stable, same as with dementia, Alzheimer's and other dementias, also remaining stable, because not many risk factors that can be modulated, and no therapeutic breakthroughs in dementia so far, unfortunately. So that's epidemiology. So let's move further to a very clinical topic that's for the first quarter of 2021. That's my paper of the first quarter, let's say. That's a publication in The Lancet, published a few weeks ago, from the OXVASC study. That's an interesting study from Oxfordshire in the United Kingdom, where they continue to follow a population. It's a population-based study of 92,000 inhabitants, and they're checked for various conditions such as cerebrovascular events. And I'll show you this very interesting study that was published in Lancet on the topic of, on the item of TIA. So many of you may, I don't know how many of you may have asked yourself, what are the criteria by which I define a TIA? You know, these many patients coming with transient symptoms, where you always ask yourself, well, has this been a TIA or not? As I may remind you, TIA is internationally defined as a sudden onset focal neurological deficit. That's simple. And now it comes, of presumed vascular origin. Yeah, what is that? There's no gold standard for that. It's just your personal presumption of something lasting less than 24 hours. That's also not difficult. But this is the problem in the definition, presumed vascular origin. And almost all of these things are based on history. And since that is the case, the consensus, even between stroke expert, of what is a TIA and what is not in one given patient, is very bad. So even experts disagree a lot of times about whether this was a TIA or not, what the patient is presenting with. So this is the topic of this paper. Let me continue with the first, with the definition. The people in Oxford, not a bad area for neurology, I would say, what they consider to be a TIA. The classic TIA, as they say, is something with a transient motor weakness. I mean, that's probably the hardest thing, because motor weakness is not influenced by much other factors. Also, classic TIA for the Oxford people is a dysphasia, a transient dysphasia, whether expressive or receptive, don't matter. It's a sensory loss in 2 or more body segments. That's interesting. So they require at least two body segments for a sensory loss, a visual loss in one part of the visual field, a monocular visual loss, of course, that's very specific. I would say vertigo is accepted only when in the context of other TIA symptoms mentioned above. Diplopia, the same, is only accepted as a classic TIA in combination with other TIA symptoms mentioned above. Same for dysarthria, same for a short episode of, let's say, unsteady gait. That's not accepted as a TIA unless it's combined with other TIA symptoms. That's the definition according to Oxford. That's what they accept. What do they not accept? It's in the next slide. They don't accept vertigo only. But I tell you, of course, that's certainly something many people will disagree upon. And that's why they call it the non-consensus TIA, or transient neurological attack of undefined origin. Ataxia only, without other TIA symptoms, not accepted. Diplopia only, so single isolated short-term diplopia is not accepted in the Oxford system as TIA. Dysarthria only, the same. Short episode of slurred speech is not accepted. Bilaterally decreased vision, this is something I would also not accept as a possible TIA. And a single segment sensory loss also not accepted as a classic TIA. But who knows what this really is? I mean, there's no way to find out unless you do two things. And that's what the Oxford people have done, and which I will show you in the next slides. You can either do the diffusion-weighted MRI in the whole population presenting with these conditions, or you can follow them over a number of years and see whether they have an increased risk of vascular events in the future. Because if it's a true TIA, of course, it should imply a higher risk of suffering other vascular events in the future. And that's what the Oxford people did, and I will tell you. They did MRIs in all these classic TIAs and all these non-consensus TIAs, and those are 4 patients from their huge sample. This was a patient with transient isolated dysarthria, not accepted as TIA. That's his DWI image. Same with isolated vertigo or ataxia, also a DWI patient, of such a patient with not accepted as classic TIA. Same with transient isolated diplopia, one example from the Oxford community, and one transient isolated bilateral visual disturbance, also not accepted as classic TIA, showing 1 thalamic and 2 bilateral occipital small punctuate DWI lesions. So all of these patients would not have been labeled TIA, but non-consensus TIA or TNA, transient neurological attack of undefined origin. So that's the first they did. And they observed that 9% of the non-consensus TIA population had DWI lesions, 9%, and 17% in the classic TIA population. So it's double as much in the classic TIAs, but still 9% in the undefined non-consensus TIA population, making it likely that many of these undefined weak events are TIAs. So second half of their study was this one. And you see the red line, that's stroke risk in the next 19 days after presentation, after the index event, after the TIA or non-consensus TIA. And you see that the classic TIAs defined, as mentioned before, have what we all know, a risk of stroke of up to 10% in the next 90 days, most of the risk being in the first 3 weeks. And you also see that the non-consensus TIAs are almost the same, a little bit less risk of stroke within the next 3 weeks or 90 days, but still much, much higher than in a normal, vascularly healthy population. So the message from this is that all these questionable non-consensus things have a similar stroke risk as classic TIAs. So most of them probably are TIAs and no TNAs. Now, let's look into these strange events a little bit more. You see here, that's the group of the non-consensus TIAs and the stroke risk again within 90 days. You see the highest likelihood to be a TIA has isolated dysarthria, yellow line, and isolated vertigo or ataxia. So among the non-consensus TIAs, those are the most likely, those are the ones with the highest stroke risk, so most likely to be true TIAs. Isolated vertigo, ataxia, or dysarthria. So let's look into the true or classic, formerly true classic TIAs. You see that the cerebral motor TIA, so the maybe one body segment or two body segments affected by a motor weakness, and this is clearly the condition with the highest stroke risk. That's confirming the ABCD square score, for instance, and the lowest risk of subsequent stroke has the transient monocular blindness, amaurosis fugax. That's the lowest one. The highest one, the cerebral motor TIA. So this somehow confirms the ABCD square score, and that was something I found very interesting in the last quarter of 2021. So now let's conclude with the clinical TIA topic and move on to another thing that caused my attention in the first quarter of 2021. That's two studies regarding mobile stroke units. So if you accept that time is brain, then of course, in acute stroke management, it makes sense to not have the patient come to the hospital, but sending the physician to the patient. And this has been studied in two big cities recently. One is Berlin, Germany, and that's the paper that just appeared in February about this big study. And the second is in Houston. That paper is not published, but it has essentially the same result and will be published soon, was presented at the ISC online 10 days ago. So let me refer to the Berlin study, same result as in Houston. What they did, they have this STIMO, as they call it, Stroke Einsatzmobil in German, so a mobile stroke unit. It's equipped with a CT, able to do conventional CT without contrast, but also able to do CT angiography. Of course, for that, you need point-of-care laboratory testing, including creatinine and international normalized ratio, so that you are able to apply contrast media, and also able to start TPA treatment while the patient is on board the mobile stroke unit. And in addition, you are able by CT angiography to determine whether this patient has a large vessel occlusion, and in this case you can drive him to a facility where they can do mechanical thrombectomy without a second transfer of the patient. So two major advantages of the mobile stroke unit: earlier TPA treatment and better targeting of the institution you send him to. The study was designed as followed. The fire brigade, that's the one dispatching the ambulances or the STIMOs in Berlin. The fire brigade sent, once they received a phone call from a patient or his family, which was suggestive of a stroke syndrome, they either sent a conventional ambulance to the patient's address, or they sent, depending on availability, not randomization, that's ethically impossible in Germany, but availability, they sent a conventional ambulance, as in the control condition, plus a mobile stroke unit, who then arrived more or less simultaneously at the address of the patient and started their work. And when the MSU arrived there and the an ambulance had already arrived, this conventional ambulance was sent away back to work, and the MSU people took over the patient. MSU is stuffed with a neurologist, a radiology technician, and a paramedic. And the ambulance is staffed by only 2 paramedics. And in addition, the MSU is also equipped with a teleradiology device where the radiologist can comment on the CT if the neurologist is not able to do that by himself. So what comes out of this study? I just show you the geography of Berlin, by far the largest city in Germany with 2.6 million inhabitants. The 3 catchment areas of the mobile stroke units, one in blue, one in green, one in, let's say, red or orange. These spots are the spots where the mobile stroke units are placed. The red triangles are places where ambulances are located, and the black dots are regional stroke units where the patients are taken to. So what came out of the study? I'll show you in the next slide. The primary outcome is this one. Not unexpected. The percentage of those with a very good result, defined by modified Rankin scale scores of 0 or 1, is 9%, an absolute 9% higher in the mobile stroke unit dispatch group compared to the ambulance-only dispatch group. It's a 9% plus by the MSU service, mainly due to very early TPA treatment. So it's mainly due to a clear increase in the number of golden hour TPA thrombolysis. So thrombolysis within the first hour has a big success, and the percentage of patients receiving a golden hour thrombolysis is increasing, and due to that, the number of very good outcomes is increased by 51 compared to 42 in the control condition. The result is not as good in the most, if you would define another endpoint, it's a secondary endpoint here, percentage of those living at home or being modified Rankin scale 0 to 3. If you would have defined this as a primary outcome, it wouldn't have been significant, quite interesting. So result depends on outcome endpoint definition. So but still, that's a positive result, and it's exactly the same as they observed in Houston, I can tell you, with the I think it was termed best MSU study presented by Jim Grotta 10 days ago. So positive study, mobile stroke unit. Is it something which we should go for everywhere in the world? Certainly not. If you look here, to treat, let's say, 1,000 people, it takes 16,000 stroke calls where the patients or the families are considered to probably have a stroke. And then by further questioning of telephone history taking, a big number of patients are then excluded. I will not go into the details why they are excluded, to then have 2,300 in the case of this studies, more or less randomized, that's not true randomization, into mobile stroke versus conventional ambulance service, to get out this small 9% more of modified Rankin 0 or 1. So it's a big expense for a relatively small benefit. And of course, it depends on the density of the city. It depends on traffic jam and things like that. It's probably something that has to be very carefully studied in terms of the expense-benefit relationship. And it certainly cannot be done everywhere else, and also not in less densely populated cities, and not in very much crowded cities, because there the MSU won't get to the patient as soon as it should. So special thing for Houston and Berlin, probably not for all cities in the world, but interesting concept, proving that time is brain. So next thing, I'll enter the topic of mismatched imaging now, and I will present you 3 papers on the topic of mismatched imaging, which is a big thing before you do mechanical thrombectomy usually, but also before doing TPA treatment beyond 4.5 hours. You usually would expect that you have proper, highly advanced mismatched imaging. I'll show you 3 papers that have been published in the first quarter of 2021 on this topic. So first is from the diffuse 3 sample. Those among you who are stroke specialists know what this is. That's one of the 7 studies proving that mechanical thrombectomy has a large beneficial effect in patients with acute ischemic stroke admitted with large vessel occlusion, occlusion within 6 hours. Other studies have widened the time frame, as you know, up to 24 hours recently. So diffuse was a study, one of the first studies, and it used advanced imaging, penumbral imaging. One example is shown up here. The green area is the penumbra, so salvageable tissue at risk of dying within 6 hours, and the more or less red, or I don't know what the question, the pink area here is the estimated infarct core based on perfusion imaging. So big mismatch between these two areas. Patient was received endovascular treatment. One was treated endovascularly. The other was randomized to TPA only. Big success for the group receiving EVT, as you know. But there are several interesting aspects about this sample. One is that the group receiving EVT and the one receiving best medical treatment only did not differ in their infarct core at the time point 24 hours. That was a very interesting and strange, surprising observation in this study. And I'll show you in the next slide one example of such a case. Two patients compared here. One patient in the left upper here at baseline receiving mismatched imaging. It's the picture I showed you a moment ago. Large penumbra, small infarct core at baseline. Another patient, other hemisphere, but very much similar, big mismatch between perfusion deficit and infarct core. So more or less the same case in two different hemispheres. Let's look about the results after 24 hours. CT defined infarct core looks like this, relatively small infarct core of the same size, and in this case here. But if you look 1 week later, you see that this case still has the small infarct he or she had at the time point 24 hours. And in this case, the infarct has grown to 3 or 4 times larger size than at the time point 24 hours. So what can this be attributed to? It's simply that this patient had no reperfusion at the time point 24 hours, and this patient had full reperfusion at the time point 24 hours. In most cases of the diffuse sample, this one due to endovascular treatment, and this one to best medical treatment alone. So what does this observation suggest? I mean, it's not a randomized study, but it suggests that something is happening beyond the time point of 24 hours, which we have underestimated in the past. So there may be a second time window beyond 24 hours where infarcts grow, and for that reason, reperfusion may come with a benefit. This is diffuse 3, a very similar study, again published in JAMA Neurology 8 weeks ago, comes from South Korea. Similar question and similar answer. I will show you the data. It's a South Korean center, one center, retrospective study again, so not the highest form of evidence, but 8,000 stroke patients observed between 2012 and 2018. And from them, 150 were extracted retrospectively because they had high-end advanced imaging of their infarct cores. And what you see here is the same as in the previous study. Patients admitted beyond 16 hours after last known well of the patient, beyond 16 hours, still show infarct growth beyond 16 hours. So the infarct in the group mean grows from 10 milliliters here at baseline to 23 at final infarct volume 1 week later. Same with the 24 to 84 hours from last known well group. Still, the infarcts almost double between 24 to 48 hours baseline and 1 week later. And this is not CT morphometry, it's infarct core definition based on high-end perfusion imaging. So there is infarct growth clearly here beyond 24 hours. And this is the same message. This could be a second time window for recanalizing treatments, of course not TPA, but mechanical thrombectomy. And from these 150 patients, they extracted from 8,000, it's a small group, of course. From these 150, 1/3 had mismatched imaging, and 1/2 of this third underwent 24 cases, underwent endovascular revascularization beyond 16 hours, up to 10 days after last known well. And this is just a suggestion, it's not high-level evidence, but it's a suggestion. These 24 had a clearly better result than the other 126, which also had infarct growth, but no large vessel occlusion revascularized. So another piece of evidence suggesting that there may be a very broader window for recanalization as we have previously thought. Last study on the topic of mismatched imaging is this one. That's from the Trival Registry. Trival Registry is a registry of, it's not a randomized controlled trial, it's a registry of approximately 2,000 patients having undergone endovascular treatment of large vessel intracranial occlusions, mostly M1 occlusions here. And they extracted a sample from this 2,000 population of 947, where they had a good imaging, and they looked whether these patients, all of them having undergone endovascular treatment and all having been revascularized, had different outcomes depending on the mode of imaging. This is the group which was revascularized from 0 to 6 hours time window based on CT perfusion imaging, so advanced imaging with measurement of infarct core. And the other group, 6-hour window, where the decision to do endovascular treatment was based solely on CT plus CTA without measurement of infarct core. It's just, let's say, aspects plus CTA, whether this is, whereas this is advanced imaging of measuring infarct core based on perfusion. And they did the same for the 6 to 24-hour group in the Trival Registry. The Trival Registry includes patients having been revascularized up to 24 hours from last known well. And you see, I don't go into details, the message of this study is that the outcome in the late revascularized group compared to the early revascularized group did not depend on the method of imaging. So even the simple imaging method, let's say like Mr. Clean, aspects plus CTA, provided the same benefit as the patients where the decision to do EVT was based on high-level imaging, doing infarct core measurement, and in many of them also penumbral imaging. So this is an interesting message for the future, suggesting that maybe the requirements towards imaging for selecting the patients benefiting from endovascular treatments may not remain as high and advanced as they are right now. So last topic, almost last topic is this one. You know, it's 39 minutes now. Last topic is the question whether to use RTPA while or immediately before endovascular treatment or not. There have been 3 studies published now. Those are the 2 from 2021. I will not go into the details. One from Japan, one from China. There had been another one in 2020. That was the Direct MT trial. This is the SKIP trial. This is the DEVT trial. All of these 3 trials taken together did not give a final answer whether to add TPA or not when you intend to do an endovascular mechanical thrombectomy with your patient. So the jury is still out on that question until 10 days ago, I would say. And I show you a photograph that I took while the International Stroke Conference online. That was from the Mr. Clean No IV study. You know, many of you will know the Mr. Clean study. It was the first to prove mechanical thrombectomy to be effective with TPA. And they did a second study, the Mr. Clean No IV, where they did not TPA, but put the patient directly to a mechanical thrombectomy. And as with the 3 trials before, this trial was inconclusive. So we did not show superiority or non-inferiority or of direct endovascular treatment over IV TPA followed by endovascular treatment. So this is the same as the 3 studies before. That's not the interesting thing. The interesting thing is the next. They did a sort of meta-analysis of all 4 studies available now, showing this. And I would say you can conclude from that it makes no difference whether you do intravascular treatment, mechanical thrombectomy, with IV TPA or without. Of course, the big caveat is that this only applies to patients where there's no further delay before you do endovascular treatment. I mean, if you have to transfer the patient to another place, of course, you should start with IV TPA, and those patients were not included here. Or if you have to wait for the angiography people for an hour, of course, you should do IV TPA. But this message that EVT can be done without IV TPA applies to those immediately undergoing EVT. In this case, you can do can skip IV TPA. That's one study from the International Stroke Conference. And to conclude my talk, I will show you a second one. And this one probably will become to be a real, I would say, modern word, game changer. It was from Barcelona, from the Catalonia strokologists. Mark Rebo is the most prominent, Carlos Molina. They presented a very interesting paper, the AngioCat trial, and I shortly show you the design of that very elegant thing. Many have done a same thing like that before, a small series in special hospitals, but they did a large-scale study, randomized prospective study of the following design. Patients being referred to the thrombectomy center in the Vall d'Hebron, Catalonia clinic, were referred from other hospitals or direct by ambulance. And when they had an NIHSS above 10, they were randomized upon entry to the hospital. They were randomized into those going to the imaging facility first. So let's say the conventional mode of management, put the patient to the CT, do CTA, do mismatched imaging, or at least ischemic core measurement. Whether those directly going to the angiography suite, where they did an exclusion of a cerebral bleeding with planar CT. And you have the more modern angiography devices have a simple, not a very highly qualified, but a simple CT measurement where you at least can exclude a cerebral bleeding as a differential diagnosis of the stroke syndrome you admitted. And once they had excluded the intracranial bleeding as a cause of the syndrome, they directly proceeded to an angiography and then evaluated the patients randomized like this at according to MRS at 90 days. And the simple thing shown here, so the direct transfer to angio suite, DTAS, was 30 minutes faster to endovascular treatment, and subsequent to that, due to that, you have an absolute 10% more of modified Rankin scale scores 0 to 2, just by the gaining of 30 minutes. And of course, doing angiography, a number of patients who may have not needed angiography, but in the sum overall, you have no more bleedings, but you have better neurological outcomes with the direct to angiography suite management. So this is something, my guess is that this will be, as said before, a game changer. Now, my summary slide, and then it's 45 minutes. Summary about the papers, the 9 papers and the 2 ISC presentations is this. In patients with COVID-19, ischemic stroke remains rare, but if it occurs, it's severe and related to the traditional vascular risk factors, which are somehow activated by the stimulus of COVID-19. Second summary is stroke remains among the 3 most burdensome neurological conditions, directly followed by migraine and by dementia. Second summary is when you're in doubt whether your patient has a TIA, he's probably having one, and you should proceed as if he had a TIA, because he's likely to have a DWI lesion and to have a similar stroke risk as those with the true TIAs that you really believe to be one. Third, mobile stroke units can reduce stroke morbidity in certain densely populated areas where there's not too much traffic jam. The time window for endovascular treatment in patients with large vessel occlusions keep enlarging up to 10 days, as I showed you, while the imaging required to make this decision apparently gets simpler, as shown before. And the last summary of my talk is omitting IV TPA begins to be acceptable in patients scheduled for endovascular treatment when there's no expected delay until groin puncture. Thank you very much for listening, and I'm looking forward to your questions or remarks. Thanks.
Okay, thank you, Professor, for your comprehensive and excellent lectures. You cover most of the hot topics in stroke, TIA, and recent stroke and thrombectomy. I have a question. Before, when we have patient with TIA and the MRI showed recent stroke, recent infarction, we are calling this one as a vanishing stroke. So we are consider it as a stroke, or consider it still TIA?
Stroke, definitely infarction. I mean, because that's also the international definition. So the TIA is only applies to the patient unless you have not shown structural tissue damage using proper imaging.
Okay, another thing, in the thrombectomy group from 16 to 240 hours, I noticed that in spite of the duration is more than 16 hours, still the aspect score is 9, 8, and 9 in most of the group.
Yeah, right. I mean that, and I mean this is. I must say the papers I have cited here and explained are no prospective studies, and it's not always quite clear, for example, how the aspect score was in these patients. But that's what I would assume also. I mean, to do an endovascular treatment in a patient 1 week after stroke onset it would be almost unethical, I would say, to do this in a patient who has an aspects of 2, where 80% of the MCA territory is already infarcted. So my guess is that most of them will be high aspects score patients with very good collateral situations, where the tissue survives as long as it does. And as the comparisons with other control groups suggests, many of them will go on to deteriorate, even if it's 6 days ago, because the collaterals will not maintain for the rest of their life.
If the CT showed the early ischemic change, and when you count the aspect score, you find it is about 2 or 3. Did you consider this one, the patient coming after the 6 hours? Did you consider this one for thrombectomy, or you consider not for thrombectomy?
If he has a large vessel occlusion, we do thrombectomy as well. And that's evidence-based, I would say. I mean, the 10-day.
You are not doing you are not doing CT perfusion or perfusion.
Sorry.
You are not doing CT perfusion or MRI diffusion flare just to see if there is mismatch.
We do it. We do it. We're very much fond of MRI in these patients, but I would not say that you have to do it, because, for instance, you should do you should have a low aspects, or you should do infarct core measurement based on perfusion imaging. But even if you are not unable to do proper perfusion imaging and infarct core measurement, I would say that if you have an aspects of 0, 1, or 2 in a patient with a large vessel occlusion, who is still symptomatic, I would go on to do thrombectomy.
We can ask Dr. Mahmoud if he has any comment.
Just thanks very much, Radai. We're proud of having always regular with us, Dr. Helmut, and a very, very good effort and very summarized capsules in point. Yeah. I do have, of course, many questions. I localize for only two simple. The Oxford study is fantastic in all aspects. And I wish they have like more digging in more details. And my question, what other DNAs common they found if they mention it? And did they have any percentage about it?
No, it's a very complicated paper. No, of course, they excluded like let's say patients with established migraine or with other known causes of transient events. Let's say Meniere's disease, things like that were all excluded, and migraine or excluded. Of course, it's only those where you have no other acceptable explanation for the symptoms.
But it opened also the research for many clinical, يعني how is the vertigo presented? So it could open the RCA characteristics. It is very fantastic, yes.
I'm very happy to hear that you find this study most amazing. That was my impression. I mean, this is a study where you say, well, why didn't I do that 10 years ago?
My second question is about the mobile CT. Is there any reported side effects? When they sometimes rush and giving the drug before they need expert opinion, which is not available at that moment?
No, in the paper and also obviously in the Houston study unpublished, there's no increase in bleedings, for instance. That would be a concern. There's no
hemorrhagic changes, for example.
There's no increase of complications of any kind.
Interesting. Okay. Very good.
And the effect they had was exclusively due to earlier TPA treatment. And interestingly, it was not due to the patient's better targeted to thrombectomy units. That had no influence on the result. That would be what I have guessed, but it's not the case. It's simple. It's TPA, golden hour TPA.
Yeah. Thank you very much.
Dr. Ashrin, do you have any comment or question?
Thank you, Dr. Hamid, so much. Thank you for the fruitful and new data from these studies. No, I have no question. Thank you so much.
Thank you. Dr. Muhammad, do you have any comment or question?
Yes, of course. First, a big thank you to Professor Dr. Helmut for his outstanding scientific activity in SGH group. Really, I get a lot of benefits and new information added to me with every presentation of Professor Dr. Helmut. I have 4 questions to you, Professor Helmut. My first question, lastly, there's a recent study about the significant reduction of disability of stroke, or TIA, this regarding adding ticagrelol plus aspirin versus aspirin alone. And in our literature, we see aspirin plus clopidogrel plus dipridamol regarding the class of evidence 2A. What's your opinion about the results of that study, which include large number of patients from 28 countries?
That was the Thales trial, TH.
Yes, of course.
That was 2020. That's why I didn't cover it in my talk. But my personal opinion on that is that from the data, it cannot be assumed that the combination, including ticagrelor, is better than aspirin plus clopidogrel, for example. So we continue giving aspirin plus clopidogrel in the minor strokes and the high-risk TIAs, ABCD square defined high-risk TIAs. So we have not switched to ticagrelor because the effect seems not to be superior to the more traditional double antiplatelet treatment mentioned.
Okay, regarding aspirin alone, you prefer ticagrelor plus aspirin or aspirin alone?
That depends on the patient. If the patient has a minor stroke, not a large stroke, minor stroke or high risk TIA, I would treat him with double antiplatelets, independent on the combination. I would say aspirin plus clopidogrel or aspirin plus ticagrelor doesn't make a difference, according to the data at least. But I usually prefer aspirin plus clopidogrel, but would not prefer aspirin alone in this patient group.
Okay, thank you.
For 21 days only. That's important because
For
the
21 days.
effect ends at, let's say, the 21st day, and then you have increased bleeding risk, but no benefit. So for short term, 21 days.
This other literature saying 3 months is, I know the guidelines 2 weeks to 3 weeks. So you don't prefer extending this to 3 months.
Yeah.
Okay.
Unfortunately, many patients don't stop taking the double treatment because they are in fear of getting an attack. So that's the problem with that. But you should recommend only 21 days.
Okay. My second question is regarding minor stroke time window regarding intravenous thrombolytic therapy. If NIHS score less than 4 and no single major deficit, would you prefer to go through RTPA regarding the new literatures or to be significant disability in order to give RTPA?
May I ask, because I didn't understand it quite well, you meant migrainous stroke?
Minor ischemic stroke with NIHS score less than 4. Would you prefer go through RTPA?
Yes.
Okay. My second question, and this is a real case I face, that I have patients with minor stroke symptoms. NIH score was 5, and I go through CT angiography. It was presented from onset of symptoms within 3 hours. And I found that this internal carotid artery disease was partial occlusion of M2 segment MCE. Symptoms was fluctuating regarding stroke severity, even before and after CT angio. Would prefer at that time waiting for significant disability in order to go through mechanical thrombectomy, or we can go for mechanical thrombectomy even at that finding?
There is currently there is a randomized controlled trial on this topic where we are taking part in. So we here in Frankfurt, in my department, would randomize this patient into one of the arms. But my impression is that most of these patients will go to deteriorate, and we would vote for thrombectomy in such cases if we would not do the study right now.
Okay. By the way, we did the mechanical thrombectomy for the patients in order we fear that he may fluctuating to the worst condition, and at that time mechanical thrombectomy will be useless. My fourth and last question regarding non-consensus TIA symptoms. We usually face that symptoms in our outpatient clinics. A lot of patients regarding dizziness, vertigo, and diplopia. Ataxia may be sometimes raise our attention, but vertigo, he may be wandering through different specialty and different causes of differential diagnosis. Regarding your study, if we give attention to that non-consensus symptoms of TIA, we will increase the number of people diagnosed as transient ischemic attack, and this will be a serious significant cardiovascular event, which need from us advanced investigations regarding MRI. Is it beneficial regarding the consumption of resources, medical resources regarding investigations to go through many patients with vertigo, going through MRI by that concept, or is there adding criteria?
Oh, that's a very difficult question, of course. I mean, as shown in the Oxford study, I mean, if you have 10% DWI positive patients in this group of ill-defined neurological attacks, that makes a difference. I mean, they are in a high stroke risk, and my guess would be that if you talk economically, that the benefit will will be higher than the cost that you apparently save by not doing MRI. So that would be the German view, I would say. And of course, we have a much different system here where everything is covered for by the insurance, and the patient doesn't have to pay by himself. So maybe this is depends on the context. But if you have 10% DWI positive, that really makes a difference in terms of managing the condition, which is a dangerous one.
Okay, thank you. That I finished my 4 questions, and thank you.
Dear Professor, we have many questions in the Q&A. One of the questions asking about the difference in managing stroke case in COVID-19 from other patients.
No difference. I mean, I would say no difference compared to other patients with a severe infectious state. So that's what I would say. Of course, if you have a severely, if you have a COVID patient who is severely ill and who's in the intensive care unit, you probably will not do TPA treatment because they have many arguments against that. So I would not treat the COVID patients different from those with other severe infections. Let me put it like this.
Okay. One question said, why most doctors asking to stop aspirin before vaccination? And does it have any harm?
Well, the harm, as I showed you, this is all nothing. I mean, we don't have long follow-ups, but the follow-up we have now is that we get this immune-mediated thrombocytopenia plus thrombosis in 1 per 100,000 vaccinated people, which is certainly not much, and which is lower than the number of those probably going to die from COVID-19 if they remain unvaccinated. So I would not argue against vaccination, but you have to know that 1 in 100,000 probably will suffer from a relevant vaccine-related complication, which will be difficult to treat. But of course, many more will die from COVID once they get it than 1 in 100,000.
Okay, so another question is same. He said after taking AstraZeneca vaccine, should take aspirin or no?
No.
No.
I don't think so. I wouldn't take it. I would, if you get headache, I would take ibuprofen, as I did after I received the BioNTech. I had the second BioNTech caused a lot of headache, and I had severe headache. If I would have known this sinus thrombosis thing, I probably would have gone to the MRI unit. So I had headache, took ibuprofen, and it disappeared. So that's what I recommend.
Okay, one patient, one doctor asking if I can give oral anticoagulant post-COVID vaccine stroke.
Anticoagulant in context of vaccination?
Yeah.
No, I wouldn't do it. Apparently, if you're talking about this complication with the AstraZeneca vaccine, this apparently seems to be caused by thrombocytopenia, paradoxically. So it's certainly nothing where you would give heparin as an acute treatment or do anticoagulation of any other kind. It's probably more, if you happen to have such a patient, I would go for either plasma exchange, IVIG, or another drug that has been described for the heparin-induced thrombocytopenia, which I don't remember the name. So you should treat it like heparin-induced thrombocytopenia and not with anticoagulation.
Okay. Another 2 questions is the same. One asking about thrombectomy in low NIH status score, and another one asking about if the patient having large vessel occlusion with minimal deficit and or has a TIA. Do you recommend to do thrombectomy?
Well, as mentioned before, same question as from Dr. Mohammed, sorry. there's a randomized control trial going on exactly in this population. So, so there's uncertainty about what to do best. We would randomize such a patient into the study, and if the study wouldn't exist here, I would personally go for thrombectomy, because I have seen many patients like this who then deteriorated 24 hours later. So my conclusion from these, let's say 4 or 5 personal patients was, if you're in doubt, do thrombectomy, because many of them will deteriorate.
Another question regarding the vaccine. He asking if, because of the chance of having thrombosis after getting the vaccine, shall we continue taking it, or we should stop it?
Take what? Stop what?
Take the vaccine. Take the vaccine because of chance of having thrombosis after getting the vaccine,
Oh,
even if it is low. We
No.
should continue taking it or no?
Well, I mean, we're talking about complication occurring in 1 of 100,000. Let's put this in the context. I mean, if you take aspirin, you get 1 death per 1,000 patients taking aspirin per year due to intracranial bleeding, gastrointestinal bleeding. So that's 1 in 1,000, and nobody would be cautious about taking aspirin. The other thing is women taking oral anticonception are on a much higher risk of getting a sinus vein thrombosis than if you get an AstraZeneca vaccine. So don't worry too much. It's 1 in 100,000, extremely rare so far.
Another question also: do you have do you give TPA if the patient have only vertigo, but the stroke, but the MRI showed a stroke?
No, probably not, because this deficit is not relevant enough to go for the risk of TPA, which is still 1.5% of getting a bleeding. It must be a relevant risk, interfering with the patient's life and not unlikely to disappear. So let's say aphasia alone would be a reason. Homonymous hemianopia would be a reason to give TPA, because these are relevant deficits, although they may have not a high NIHSS, but vertigo alone is likely to disappear even if the labyrinth is dying. So this is probably nothing that will affect the patient in a serious way.
That's the question we have here. If the patient have atrial fibrillation and receive TPA, do you recommend giving aspirin after 24 hours, or we are waiting for some time to give warfarin or no?
If the patient was taking an oral anticoagulant until the day of stroke, of course you will not.
The patient having a stroke after atrial fibrillation, and we give him TPA after 24 hours. We give aspirin, or we are giving warfarin and or new oral anticoagulant. I
see. We would, depending on the size of the stroke, of the infarct area, we would start with warfarin on day 1 if he has almost no infarct area. If the CT remains or the MRI remains with a very small infarct area, we would probably wait 1 or 3 days. And if the patient has a large infarct, we would wait for 2 weeks.
Okay. Dr. Mahmoud, Dr. Ashirin, Dr. Muhammad, anybody having any question in the Q&A?
Thanks very much, and we appreciate so much Dr. Helmut's effort.
I have just a question, not sending here, but one of them asked me in order to ask it for Professor Dr. Helmut about the role of the ischemic acid in spontaneous intercerebral hemorrhage. There is at least released randomized control trials in that the issue shows significant reduction in limitation of expansion of the volume of hemorrhage, but still 3 randomized control trial. One of them was very small, the other 2 moderate amounts of patients, but not much evidence. What do you think of that issue?
I only understood parts of the question, so I'm not sure whether I really got the question. Sorry.
Role of the ischemic acid in limitation of expansion of spontaneous intercerebral hemorrhage.
Tranexamic acid, huh?
Yeah, yes. What's your experience in using it?
we don't use it. According to the trials, which were not really, did not prove benefit, we don't give it.
Okay, thank you. Thank you.
So Helmut, can I ask you a question, please?
Yes, of course.
I need to know what's your experience with the tenecteplase?
Yeah, it's not approved in Germany, unfortunately. So the only thing I know are the trials that have been made, and I see that in other countries it's available, but in Germany it's not available, which is a surprise since it's manufactured by a German company, as you know. So it's not available here. So I have no personal experience, but it's a very promising follow-up to alteplase, probably.
Yes, yes, sure. Thank you.
Okay. Thank you so much, Professor Helmut, for your lecture. I hope, inshallah, we see you this year.
I hope so too.
Physically, and we'll have a lecture also physically. And thank you for Dr. Mahmoud, Dr. Ashreen, and Dr. Muhammad, and all the attendees. And thank you for the organizing committee. And see you later, inshallah.
Masalama.
Assalamu.
Thank you.
See you.
Assalam.